All right, so what you should know, neuro lecture number 2. Going to cover neuroanatomy, head injury assessments, cranial nerves, head assessment, ICP, and finish up with neuro 7. All right. All right, so some basic beginnings, all right, with this is, think about it, right? So what's the big thing we're talking about when we're talking about neuro? Is neuro is like a light switch, all right? So when you have a neuro problem, it's like a light switch. So it's either the damage is done or the damage isn't done, right? So, that's it. Because once you have a neuro problem and the damage is already done, that's it. Now we have to basically make that person function at the highest level that they can at that injury. So think of a stroke, right? So a stroke where a person, might have weakness on the left side or something like that, and they having difficulty speaking. And if they're having difficulty speaking, that's it. The stroke has already happened. So, now you're just in rehab, and you're just in a case where, you need to go to rehab and try to get to the highest level. You think about that, Dick Clark, right, from New Year's, in his speaking, right? He wasn't able to speak that well, right? Even though he had the greatest rehab around, because once the damage is done, that's the only level of function that you're able to function. It's not like an iron, right? So everything else is hemodynamic, okay? So, and that's an important part, is because hemodynamics is pathophysiology, right? Which is, if the low volume is there, the heart rate will go up, and that heart will start to pump go up in order to deal with that low volume. So with normal body physiology, it's more like an iron. And some people say, like, this is more like a male, once he's on, and then when he's off, right? And a woman is more, well, whatever. Whatever you're doing here. And it's more like an iron. You turn it on, it's cold, then it gets a little warmer, hot. And then even when it's shut off, it takes a while to start to cool off. So that's kind of how it works, is that in normal physiology, we have this going on. We have normal hemodynamics and normal hemological structure. But in neuro, we have like a light switch. It goes on, and then it goes off. And we're trying to figure out how to prevent it from causing the problem. But once the problem is already caused, then it's a rehab case. All right. So what's the takeaway on this, right? Is put your neuro hat on. Right? When you're in a neuro question, especially with the NCLEX and especially with tests, like when you're talking about a comprehensive test or anything like that, put your neuro hat on. Because if you don't put your neuro hat on, you can miss it. And you'll start to think about, what's going on here, hemodynamics, where this does not count in neuro questions. It just counts to have your neuro hat on. And that's what you have to do. So when you're looking at just certain questions and NCLEX questions and, comprehension questions and stuff like that, what you have to do is say to yourself, okay, this is a neuro question. I'll put my neuro hat on, and there I go. All right. And then you'll forget everything you used to know about normal human dynamics, because neuro is specific to neuro. All right. So basically how I start this lecture off is that think about everything you used to know, forget about it. Because for neuro, it is content, it is understanding, and we try to just basically stay within the neuro focus. All right. Next thing. Crap. All right, so the next thing is anatomy. All right, so what are you responsible for? Well, in nursing too, you cover stroke. All right, so I don't test on stroke. So this is non-testable for me, right? Because I don't really talk about right-sided versus left-sided and so on and forth, because it doesn't really, you've already been tested on that. Broca's area, speaking, aphasia, all those type of things. Because That's a chronic thing, that's a rehab thing, and that's not what I talk about. However, they talk about FAST with stroke and basic physiology of stroke. So that's non-testable in my area. So what's stroke about? What are you tested on? Well, when you're looking at stroke, you're looking at the circle of Willis. And this circle of Willis is stuff you learn in nursing too or not. And what the principle is that, you know, when somebody has, you have your, goes down to your carotids. So you think about carotid arteries, right, down here. This is not, there's a couple bifurcations, but generally on carotid arteries, we talked about this earlier, was that, you know, if you get stenosis in these carotid arteries, you'll have syncopal. All right, and syncopal is, you know, passing out, you know, so, which means they get the $1 million workup, right? What's the $1 million workup? You know, get a CT of the brain, you know, and figure out what's going on in the brain, because you shouldn't just pass out. And that's the normal mechanism for the brain, is that when there's a problem going on, it generally will reset itself. So this circle of Willis, why is this important? Well, on these carotid arteries down here, you could have stenosis, which could cause a syncopal episode, but you could also have a clot. And that clot can come around and basically go up here into the circle of Willis. And this circle of Willis is, you have your right side and then you have your left side. So basically a right-sided stroke will be over here and a left-sided stroke will be over here. And that's kind of what they're talking about, is that, so at that circle of Willis, it's a crapshoot. You know, it's basically that, you know, you either make a choice of which side it's going to go through. That's a dice. And, you know, that's why somebody gets a right-sided versus a left-sided stroke. Now, what do I... So I'm covering this stuff so you know what not to study, right? I mean, because that's a big problem with this content, because it is big on stroke and big on these other things, but you've already been tested on it. So when you're thinking about this content, you say, what's going to kill my patient now, right? Is this going to kill my patient? If it's going to kill your patient or potentially kill your patient, then you're studying it, all right? So what does that mean? Well, on a stroke, it's only at the immediate time right now that there's a problem, right? And once the treatment's been done, then they're in a rehab case. So we'll talk about the other aspects of what you need to know. So I don't also test on this stuff, right? So as far as the frontal lobe makes all the right decisions, so think of the front office. And this is all stuff that is tested on in Nursing 2 or Nursing 1 and stuff like that, because this is all A and P, right? And chronic. So this means that this stuff is not tested on in my course because it's already tested on. Now, what you're responsible to know is you need to know this stuff, because it is stuff that you have to go back and re-put into your brain, no pun intended, because so that you're able to memorize this stuff, and you have to know this stuff, because how NCLEX will test this is that they'll say there's a frontal lobe injury, and then that's how it is, right? So, or if it's in the parietal lobes and different things like that, and this is what they're looking at. So if you're unfamiliar with this and you have, you know, or you have a deficit in this, you know, this is something that you would have to go back and study, but I don't test on it. I expect you to know it, but I don't test on it per se. All right. Next thing I don't test on is this, which is, hold on one second, sorry about that. I just need to make the screen correct. Which is tested on Nursing 1, right? Because Nursing 1, you do your spinal assessment, you do, they talk about, crap. Sorry about that, guys. Where you take this little stirrup thing and which is for the spinal thalamic helmet, which we'll talk about a little bit later when we talk about assessment. And, you know, I talked about this in class a little bit about, you know, I mean, me going to the doctor, you know, and, you know, giving the doctor the finger, because I had bilateral, you know, numbness in my middle fingers, right? So I was like, hey doc, what's wrong with this? You know? And, you know, he's like, well, you know, he feels my joints, and he's like, oh, it's arthritis. And I said to him, I'm like, well, what do you mean arthritis? I mean bilateral arthritis, which is a concept, right? Because bilateral, things happen bilateral, it's generally nerve, okay? And so you can see here with their spinals, and it goes right here. And it was an actual pillow issue, right? So I was sleeping, and then my head was like, you know, up, and, you know, stuff like that. And it was causing some cervical pinching. And that was resulting in this. So I changed my pillow, you know, happy, and then I no longer flipped off my doctor. And so that was helpful, right? I mean, for both of us. And so the principle is this, is that so bilateral tends to be chronic, right? Where ipsilateral tends to be acute. And we talked about that before. So I don't test on these dermatomes, it's called. And this is when you do that pain, right? And sometimes this tends to be somebody's, like, you know, sex toy and stuff like that. They use those for those. And then, or you bring out the feathers, right? So where you're testing, you know, sensation and soft versus painful touches. And this is when they rub this around onto their organ, not organs, but their body, and look for sensation. And that's a neurological assessment, right? But that's chronic, right? So when would we use this acutely, right? I mean, we talked about this with Guillain-Barré. Remember, we talked about how we're waiting for them to get sensation back. And a lot of times this is what we're looking at, right, when we start to do it. Now, you don't necessarily will have this little device. You know, a lot of times, sometimes neurologists will just come in with a pin and just poke around, poke. And that's what they'll say, you know, so that's what they're kind of doing, you know, and then they'll also do, you know, soft touch with like feathers and different things like that. All right, so this is also not tested on in this context, right? Because I don't really get into that, and it's chronic, right? So what are you tested on, right? I mean, what's going to kill the patient? That is brain, right? So we're going to talk about intracranial ICP. And ICP is, if you think ICP, think of a bolt in their head, because that's how you get in that pressure, right, in ICP. Or the patient had a previous injury, and we suspect ICP. And what's the mechanisms of actions? Why do we care, right? Well, it could kill the patient. How does it kill the patient? Well, this is a closed system. And we talked about that with neuro and spinal tap, right? It's sterile. It's a closed system. So if it's closed, which also means that that person can get blood in their brain and they can herniate and die. And that goes against rule number 1. Gilliam, MG, ALS, and the neuro exam. No, you've already been tested on that. So that's why it's broken apart. I used to do it that way, but what I found is that neuro test was horrible, and just because people couldn't grab all those contents and throw it together. So now I've separated them apart, and so this will just be, you know, spinal and brain. All right, and we're going to talk about it, but I'm covering all the facts of the things that you don't need to study, because you have to read through all this content, and, you know, I mean, it's based on just basically the most acute things. So when we're also talking about like meningitis, right? So meningitis kind of covers in nursing 2. It shows up in nursing 4 with Brenda. And so the basic mechanisms of lights, you know, it's all intracranial pressure though, right? But I don't really test about like, oh, the patient had strep or the patient had this and stuff like that, because that stuff, that content base has been tested on. So you'll have topics in your ATI and IGI about these contents. So what are we studying? You know, and that's why we'll cover everything that we're going to be studying. But it's important to see what we don't study first, and that's kind of what we're doing now. All right. So are you still responsible for it? Yes, for your NCLEX you are. You know, and that's kind of why I still go over it. All right. All right, so let's get into what we're responsible for. All right. So now the principle is this, is that subdurals, subdurals, epidurals, subarachnoid hemorrhages. Okay. All right. So these are the main things that we study. All right. This is what we're responsible. Why? Because this is all episodic. And episodic things are acute. And why are they acute? Well, think of a PE. Right? PE is episodic. A normal person walking around, or with a DVT or something like that, that goes into the pulmonary embolism, right? That's episodic, right? So these are all bleeds. And these bleeds are episodic, generally. Now, there is some pathology as far as hypertension, and this is all chronic stuff, and this is why we treat, hypertension, because we don't want that person to have a subarachnoid hemorrhage, like a stroke. Okay, and we're going to talk about each one of these individually, and but why this image, right? Because anybody can get these kind of injuries. So there's a thing called coup, right? Head goes forward, counter coup, head goes back. So what can happen is the person can have injury on their front and injury on the back. So if a person is driving along and they hit a tree, right? Depending on whether or not they have their seatbelt on, is a mechanism of injury. Okay, so that's why whoever comes in will get a head CT. All right. So there's also here blast injury. Okay, that's not tested on, right? That's not most likely, right? Most likely is a person gets into a car wreck in a car accident, right? So or gets trauma to them, but not most likely. This is more war related. But you see that a lot with like post-war syndromes, but not tested on. All right, so head CT. So why do we do a head CT? Well, we need to figure out, are they bleeding? Okay, and that's the first key. So that's the first thing that we want to look at. Are they bleeding, or are they not? And then when we figure out that, we'll go to the next step. All right, so here's some things, some indications. So GCS, so we've talked about GCS before. We're going to cover it again today. Glasgow Coma Scale. And you can see here. So if level of consciousness amnesia within 24 hours of the event, they're going to get a head CT, right? So a change of level of consciousness. So the rule is that generally if somebody comes into the hospital and they had a syncopal episode, change of level of consciousness, they're going to get the $1 million workup. They're going to get a CT. Let's figure it out. But it's going to be without contrast first, right? And that makes sense because you don't put contrast in if they're bleeding. Because then next thing you know, you've got this contrast all seeping out into the brain, right? So that makes sense. So no contrast, right? And then we have cake man, right? We talked about that with renal. And those are contraindicated with contrast. All right, so let's look at these individuals. So behavior is abnormal, right? Somebody comes in disoriented, right? Or we don't know what's going on. They were found up on the side of the road, this, that, and the other thing. They're not quite acting themselves. So we have a mentation change. And we talk about mentation. We talked about before, we said that a person is generally alert and oriented ×3, right? And we said that that is a normal person. And we said that that's dependent on volume status, that's mean arterial pressure, blood pressure, all these factors. That's why when a person has a low volume, they start to change mentation. And that's why that's number one to look at the patient when they have a change of level of consciousness, because change of level of consciousness always requires assessment. And that's why those patients you see first. Okay, so if that behavior, we said they're alert and oriented times 3. All right, we said that a person will generally lose orientation in an organized method, which they generally lose time first, then person, place, then person. And we said we use this in a relationship to, alcohol. That's old school, like jug. If you've seen cartoons, you see that. All right, so when you drink, right? So, I mean, you lose track of time first. And then, somebody starts throwing in shots and everything like that, then you lose track of where were we, what were we doing, and what was going on. But you never really think you're Superman, right? So you never really think that you're, somebody else. So, and generally our elderly go in the same way. They lose track of time, then they lose track of place. And then we talked about that before, where you don't move a patient, there's a cleft foot, you don't move a patient into a new location generally when they're elderly, because they've already started to lose track of these things. And, now we're kind of losing track of time, because we're forced into our own environment. When you're forced into your own environment for any length of time, your mentation starts to, that's why you have to break it up. And you start to lose track of days and when things are and different things like that. It doesn't mean that you have a brain injury, I mean, it just means that just the same thing that happens with elderly. Okay. And that's usually an accommodation factor. All right. So emesis retractable, that's a key thing. They're vomiting. Okay. So that's a big rule. Any patient with a head injury that vomits, that's acute. Always acute. All right. And always call the doctor. That's always problematic. So if you have a meningitis that is vomiting, I mean, that patient's going to herniate and die, So, I mean, that's important. Age, just because general age. Now let's, on the brain, smaller brains is called atrophy and generalized. And that's a normal finding, generalized atrophy. Right? So generalized is chronic, and that's normal. If they have a bleeding disorder, I mean, that makes sense, right? Because that bleeding disorder means that there's blood up here, and it's causing pressure. And if it's causing pressure, that means increased intracranial pressure. Altered mental status, well, that's just change of level of consciousness. And if you see an obvious skull fracture, I mean, common sense, right? They'll get a CAT scan. Or hematoma, potential, right? Potential for injury. So you're going to scan that person. If it's none of these, they'll just observe. Okay. Now this is not really tested on. However, this stuff makes sense, right? As far as just a normal method in the way that we look at CAT scans and what we look for ERs. ERs are very predictable. I mean, it's not like Grey's Anatomy. Well, people are banging in the back and stuff like that, but I mean, it's not like as exciting. So it has moments, but after a while, it's all bellies, chest pains, and what it is. I mean, you're not always in the trauma room. I mean, you'll be you could be in the trauma rooms in the beginning, I mean, and then, but everybody gets rotated through a trauma room. Usually your senior nurses do the trauma rooms, and then you orient people towards the trauma rooms, but you kind of rotate through the different things. Because if you're in a trauma room, it doesn't mean that everybody's in that room with you. You're taking care of that patient unless you need somebody in immediate trauma. Then everybody's there, and then that's a trauma setup. We'll talk more about that when we get to trauma shock, which will be the next unit. But we're talking about neuro. So we talked about bleeds, and we talked about head CT, subdural, epidural, And okay, so subdural slow, epidural fast. Okay, and subarachnoid, worst headache of my life. So think stroke and think aneurysm. Okay, so those are the three right there. We're going to talk about them more in depth. And whoops. So let's talk about this. So we'll talk about subarachnoid first. And in subarachnoid, there's a burst, right? So let's think of stroke. And that's the main factor with it, strokes. And, whatever. And sometimes this little aneurysm, right, can actually bulge out and can cause increased pressure, right? But there are risks for bleeds. And the problem is they're bleeding out inside here. And, that is a stroke, right? And that's why we're trying to figure out, is it ischemic or is it hemorrhagic? So subarachnoid is acute. Now. Deal with it now. Patient with a post-subarachnoid is a stroke patient, right? Can somebody else get a subarachnoid hemorrhage or a hemorrhage who are not stroke patients? Yeah, of course they can, but that's not most likely. Okay, so always remember subarachnoid hemorrhage is acute, and risk is they're filling up with blood in the brain, and the risk of herniation of their brainstem into the back, and that's the not the foramen ovale. Yeah, I don't have time to think about it. Occipital ovale. Anyways, the brain can only hold so much fluid up here, so it's got to pop out somewhere, and that's generally where it pops out, in the back of the brain, back of the skull, and then they herniate. And we'll talk about that today. That's the major problem with brain injury. Traumatic increased intracranial pressure is we're trying to prevent that person from herniating and dying. All right. Are there any questions right now? All right, moving on. Okay. All right, so let's go further, right? So we just talked about subarachnoid hemorrhage, and then we just talked about now we're going to talk about epidural versus subdural. Now we said before subdural slow, right? Sub slow, and think epinephrine, right? Epi fast. The reason it's fast is because it's arterial, and the reason it's slow because that's venous. Okay. Now a patient with trauma, and we said that there's either a coup or a counter coup. Coup is just going forward, and counter coup would mean they went forward and back. So they have damage on the front and damage on the back. So it could be both places. So a counter coup is more acute than a coup, right? Now, the big question is it a concussion or is it a contusion? Well, concussion goes home. And gets monitored. And a contusion is a bruise and a potential for bleeding. So they get admitted generally, and that's the big key. How do I know it's a concussion or a contusion? That's where I have the CT scan to look at the brain and then to evaluate: are they bleeding? Are they not? Do they have a bruise, or do they just have a concussion, no bruise? And that's the difference. All right, so what's the treatment? Well, subdurals generally will get monitored, and epidurals will generally get admitted because this is acute. What's the risk of this? ICP, increased intracranial pressure, quickly, and then herniation and death. Okay, so we want to prevent that from happening, right? Rule number one. Well, subdural is, you know, a slow bleed. So these type of patients, they're still bleeding, right? So there's a difference here. These are both bleeds. So that's different than somebody who just has a concussion. Concussion, they just kind of rack their brain a little bit. There's no bleed. There's no bruise. So the brain is just kind of has a concussion. Oops. So it's not acute. They look a little goofy and all those type of things. So what do? We send them home, right? And we have to keep them awake. We say don't go to sleep right away. Don't take narcotics. Why? Because of sedation, right? And you can't evaluate Glasgow Coma Scale, mentation, if you're getting narcotics. Oh, but I have a lot of pain in my head. Well, I mean, we can't give you narcotics. So take Tylenol. No NSAIDs, right? Obviously, bleeds, right? Potential for bleeds. So a contusion, even though it's bruised, and this is why they come in, they could bleed, right? And that's the concern, all right? And that's why they get admitted generally on a contusion of the brain. All right, so quick recap, right? So you have a subarrachnoid bleed, which is a acute stroke, episodic, you know, usually related to hypertension or severe trauma, different things like that. Then you have a subdural or an epidural bleed, could be from a contusion or trauma, coup counter coup. And then you have concussion. And concussion is no bleed. You monitor, don't give narcotics. Now, you wouldn't give narcotics to a subdural, epidural, because mentation is key. How are you going to know the change of level of consciousness? Because that's everything you want to know right now, is the level of consciousness. And how will you know that if you're given narcotics? And that's why we generally don't give narcotics with head injury patients. All right. All right, so let's repeat. All right, so let's recap. So we said concussion versus contusion. They would get a CT to evaluate that. And then we're trying to think about is this person, you know, bleeding, you know, arterial, right, which would be epidural, or subdural, which is venous, and that's a slow bleed. They can both herniate and die because ICP increases because it has no place to go in the brain. Because this is a closed system, right? So, you know, just think about that. You have a closed system. There's no place. You know, now, let's talk about, like, you know, you have the dura mater and all that stuff, but you're not tested on that. That's, you know, that's more than you need to know, right? I mean, then NCLEX will never test on that. They'll test on what does a nurse do for a patient with a concussion? What does a nurse look for with a patient for contusion? And the whole concept is always about ICP. Well, if somebody has meningitis, like an inflammation in their brain, right? They have an increase of ICP. And that also makes sense because, why? There's no place for it to go. So the person, you know, could herniate. Now, there's some specific things with a meningitis is you got what's called mucorigidity, right? Where the head flexed is going to cause some pain, or Brzezinski's, right? That's different than Babinski, right? So Babinski is what we see for, you know, babies, right? The flaring of the things, of the phalanges. All right, so So contusion mean, yes, a contusion could mean a subdural or epidural hematoma. Yes. It doesn't mean it is, right? I mean, it's just a bruise on the brain, but we would monitor to make sure that it's not going to bleed. So that's why a contusion will generally be admitted, because they need to be monitored overnight, just to make sure that, you know, they're not increased intracranial pressure. All right, so let's get into it. Let's talk about application and why do we do cranial nerves, right? I mean, the main reason for doing cranial nerves is assessment. And why do we assess cranial nerves? I mean, you learn it in nursing 1, you're validated on it, right? So, I mean, it's acute. And the reason is that's how we can tell bleeds, strokes, and any other problems like that is going on in the brain. So if you think about your cranial nerves, right, your cranial nerves are up in the brain, right? And that's where they bifurcate and come down, all right? So let's talk about it, right? So what are you responsible for? All right, so let's start with cranial nerves, right? So we start with the face first, and we all have one nose, okay? So cranial nerve 1 is olfactory, right, which is a loss of sense of smell. So you don't bring a person with cranial nerve 1, you know, flowers, right? I mean, it's not a good gift for a person with cranial nerve 1 because they can't smell it, right? So they have a lost sense of taste. You know, I'm curious about this cranial nerve 1 and COVID, right? Because that tends to be an indicator, right? I mean, for COVID, right? Lost sense of taste, lost sense of smell. And I'm not a neurologist, but, you know, I mean, I know some things, and, you know, it's kind of curious to me that they go together, right? Because of, you think about the light switch, okay? You know, on, then off. So something must be affecting it. And like I said, I'm not a neurologist, so I don't know, oh, well, the cranial nerve is on the circular willis, on the fifth intercostal space of the whatever cannibulum bin, and who knows, right? So I'm not, that's why I don't do neuro, right? But neuro's predictable. And when neuro's predictable, there's going to be a sense of inflammation on that cranial nerve, 1. So one knows to smell, okay? So we always think in application when you're thinking about this. So, you know, when you think about an NCLEX question, right? I mean, what's a good gift, you know, to bring in? You know, what would you say there's an understanding or education is that the family member wants to bring them flowers or whatever. I'm not saying that's an NCLEX question, but that's how application of that cranial nerve works. Now, the problem is in nursing 1, you just kind of learn, no, cranial nerve 1, cranial nerve 2, on top of Olympus tops or whatever the hell that means, you know. But you don't learn the application why you're doing what you're doing, and that's the most important of this. So cranial nerve 1 is olfactory. Cranial nerve 2, right, you need 2 eyes to see. Okay? So 2 eyes to see, now you think about that. So what does that mean, right? So an application of this, you need 2 eyes to see around, right? So you think about that. If you're walking down the hallway, right, and somebody comes in, you know, with a wheelchair, right, on the side, they're not going to see that person, right, because they can't quite see. So they have to have things kind of in front of them. So at a bedside table, if they're sitting there, you don't put the incentive spirometer to the side. You put it in front of them so that they can see it. I don't know what the hell drawing that is, but so basically you need 2 eyes to see clearly, to see spatial, and that's when we start to test, right? Accommodation, those eyes, right? We bring our fingers and we'll say, hey, can you see me? That's the other thing coming in. And the reason we're doing that, we're basically checking that cranial nerve, right? And where that's intact or not. So 2 eyes to see. All right. Cranial nerve 3, right? So C3. Okay, so C3, P, Oh, right. So that's what I used to say. That was, my Star Wars reference. But, George Lucas, it's like, you can't say stuff like that. I have that copyrighted. So I can't put it on a sheet or anything like that. So I just said C3 pupils, right? So it's just pupils. And we'll talk about that today. So pupil dilatation, right? So meiosis versus mydriasis, right? We'll talk about that. So that's where we check the pupillary response. So we check a light, shine it in there. Okay, so what's the application of that? Well, first to go, generally, in TBIs, right? Some sort of intracranial pressure problem. Once you start to see problems in the eyes, which tends to be first, that's why we do neuro checks in the eyes first, is, because the eyes will tell us, because it's common sense when you're thinking about the pressure in the eyes, okay? And you're thinking about, if you have the eyes here, and you think about the muscles, you think about the vasculature and all that stuff, and you have this extreme pressure being caused on this, right? It's going to cause pupillary problems, right? We'll talk about that later too. So think about eye dilatation and pupils. Think about like what I was talking about, right? So you think about, giving the doctor the finger, right? I mean, true story, right? So pain in my middle fingers, right? But was about pressure of my cervical, was causing this pressure. Same sort of style, right? So I mean, that pressure is causing a problem back here. So think about bleeds, think about hemorrhage, all those type of things, right? Slow, sluggish. That's not drugs and medications. We'll talk about that later when we do pupillaries. All right, C3. Okay, so C4, the next one. C4, the next one. So C1, C2, 3, 4. C4 directions. Up, down, right, left. Okay? So can you look up? Can you look down? Okay. Right, left. Right? Oculomotor. Right? Looking up, right, left. Okay. So C5. So C5, scrinch. C5, phi, trigeminal. Right? Trigeminal on the side, right? So if you're looking at the person and they have a trigeminal here, they can't quite smile, right? Oh, no, sorry. They can't quite, it's called, I call scrinch and grinch. Their ability to chew and those type of things, they can't quite masticate, right? So they can't quite chew and chew their food. So they tend to get a little bit more of a soft diet, those type of things. That's different than swallowing. We haven't talked about that. But this person with a trigeminal, they tend to pocket food on the side of their tongue and everything like that. Okay, can't quite with the trigeminal do it. They also can't quite furlough their brow or scrunch, right? So I call scrunch and grinch. All right, so C5, C6. Now let's look at the directions of the eyes, right? So diagonal, C6, C6 directions. So now we're going diagonal, which is different than C4. C4 was up, down, right, left, and then C6, 6 directions. Okay. C7, lucky 7, smile. Okay. That's affect. And then put some earrings on them, right, like this. C8 is gait. 8 is gait. So the principle is that a patient, you or I sitting here right now, okay? So you or I sitting here, standing here, right, or sitting in the chair, you know, your C8 is engaged. It keeps you standing straight, right? Like, you don't tell yourself to stand straight, it just does, right? Same thing with sitting in the chair. You're not slouching over in the chair, right? Because you have a cranial nerve 8 that is engaged. So the principle is that if you have cranial nerve 8, you're able to sit straight up and maintain your sense of balance. Right, so think about this in the conceptual thing, right? So that's why they get the $1 million workout, because generally as you're walking along, you should always be cranial nerve 8 is engaged. As you're sitting there in a chair, even though you might be sleepy, you know, cranial nerve is engaged and keeping you moving, right? So the principle is that when you have a cranial nerve 8 engagement, you get this kind of person that falls out of the bed or falls out of the chair, you know, and you're looking at them, and then the wheelchair, you pick them back up, and then they go back down. They pick them back up, and they go back down, because you have no cranial nerve 8 that is maintaining this structure, okay? So now think about this on a normal person, right? So think about you standing, you know, straight up, and you're standing straight up, and we teach this. I teach this up at I'm part of the stat team over at Global Foundries, where we do training for the, you know, I mean, there's a lot of toxic chemicals there and stuff like that, and we train on those and emergency response and stuff like that. And, you know, because actually COVID's a big deal, you know, because they have a lot of people from overseas over there in China, Japanese, and it's Global Foundries. It's a chip plant, so I'm not being, you know, it's just what it is, population. So, so you have a high influx from overseas into that place, and so there's a lot of COVID there. All right, so anyway, so we teach this principle because a lot of times what happens is if they're doing piecework, not piecework like as in, you know, the dove, you know, I can't even draw a dove, you know what I mean? Well, what the hell is that? That's an amoeba. All right. Anyway, so if they're doing piecework and they're standing still this whole time over and over again, what happens is the cranial nerve 8 sometimes doesn't get engaged, and so they get dizzy and they pass out. So a lot of times what they'll have is mats there, you know, which keeps your body always kind of engaged. So we teach them, right? We teach the stat team and everything like that, recognize this error. We see this more frequently when we're talking about patients with, not you or I, if you go to a wedding, right? So you go to a wedding and you know, the person is, you know, getting married, and, you know, I don't know what I'm drawing here. Maybe a pope, maybe. And, you know, he's saying, no, you know, you get married, but this person's all locked knees, right? And they're locked knees for a period of time. And then what happens is cranial nerve 8 says, wait a second here. What the hell's going on? They're locked knees because you're physically forcing yourself to be locked kneed. And because you're physically forcing yourself to be locked kneed, cranial nerve 8 starts to be disengaged, and next thing you know, boom, they fall down, they pass out. So you see this a lot of times in, you know, in the military and different things like that, when you're forcing yourself to physically. So think about that. That's a mechanical, mental process. You're sitting there saying, stand straight, right? So the brain doesn't know that you're physically saying that because you're saying that, right? So then what happens is cranial nerve just recognizes that disengagement. Next thing you know, the person falls over. But usually we catch it before. We usually see them go back and forth, go back and forth. We're like, uh-oh, here they go. Next thing you know, the big problem is what they hit on the way down. And sometimes, you know, if they're in church or something like that, they may hit a hard pew, you know, I mean, that's made of oak, you know, and crack their head open. And now we have a increase into cranial pressure. All right. So that's cranial nerve 8. All right. So cranial nerve 9, right? So 9 is dying. Okay. So just think 9 is dying. And what does that mean? So cranial nerve 9, dying, swallow. Okay, so swallow vowels, right? Swallowing, peristalsis, you know, they get food in their stuck in their throat, They have a risk for aspiration, all those type of things. So that's cranial nerve 9. All right, so then cranial nerve 10. So you see this arrow right here, right? So then I usually draw a heart right here. Okay. So cranial nerve 10 is vagal, right? Which means that they become bradycardic. Hence, we vagal when you're sitting on a toilet, or like my 14-year-old who sits on that for 45 minutes. And so I show him pictures of anal prolapses. Say this is what's going to happen if I'm sitting on the toilet too much. But it didn't. He's not really buying it. He'll never get it out of his brain. But anyways, so sometimes you'll vagal, right? And then they fall out of the toilet, right? Fall off of the toilet. And sometimes that can cause a major problem. It means what they hit on the way down, you know. So that's vagal. That's cranial nerve 10. Now, if you have, think about this. If you have damage to that cranial nerve, and it's related to intracranial pressure or different things, that's why you start to see bradycardia with neuro problems, neuro patients. Okay? And that goes against, that's why I said, you know, when you're thinking about neuro, forget everything you learn, because in shock, heart rate goes up. Doesn't go down, but in neuro, it goes down. And we saw that with myasthenia gravis. Neuro, bradycardia, all that stuff. All right. What else we got? Cranial nerve 11, right? So cranial nerve 11, just draw 11 right here. Right, shrug your shoulders. So naturally, you know, and so these people with cranial nerve 11 would have difficulty, you know, transferring, you know, getting out of a wheelchair, moving to the next thing, you know, those type of things. Just can't quite shrug their shoulders. So pivoting, those type of things, you know. All right, so then cranial nerve 12, stick out your tongue, you're done. So that's glossopharyngeal. Okay, so the tongue, you know, moving food, swallowing, all those type of things. So cranial nerve 12 is your tongue system. So let's recap this real quick. All right, so cranial nerves, let's go through it, all right, because that was a long haul. We start with the face. So cranial nerve 1 is olfactory. So that's your nose. You have one nose, and that's where you start. Cranial nerve 2 is 2 eyes to see, so spatial relations. So things around, they can't quite see in the sides. They can't quite, so you'll have a clear passageway for these patients and different things. Cranial nerve 3 pupils, so pupil dilatation. Right? So mydriasis versus meiosis, and pupil reactions. We send that tends to be first. It doesn't mean it's 100% first, but it tends to be first for intracranial pressures. Then next thing you know, you say C4 directions, up, down, right, left. Muscle is now involved, atrophy, damage. And then C5, so scrunch and grinch. So, and also some problems with chewing and mastication, right? Because the trigeminal's right there. So C5, C6 directions now, diagonal, right? So up, right, left, right. So they tend to be a little more droopy and can't quite have deviations of their eyes. And then C6, C7, C6 directions, C7, lucky 7, smile, so affect, all those type of things. That's why they tend to have droopy face. And then C8, put some earrings on them. 8 is gait. And that's walking around. And also, we talked about like sitting in a wheelchair. They tend to slope over. C9, 9 is dying, moved on down. Swallowing, that's what we do, swallowing vowels, depending on if this is engaged or not, risk for aspiration, and also changes of food, the nectar, thick, you know, all that stuff. C9, draw a heart. C10, heart, vagal. C11, shrug your shoulders. And C12, stick out your tongue, you're done. Glossopharyngeal, C12. All right, those are cranial nerves in a nutshell. You know, I mean, it's a repeat of what you learned in Nursing 1 and Nursing 2, but, you know, I mean, it's more about the application, right? So, I mean, that's what you have to do when you're looking at cranial nerves, right? It's more the application, not so much the testing. I mean, the testing's pretty simple. I mean, cranial nerve, you know, 2, you know, I mean, you're just checking oculomotor, right? I mean, you're going from there. Like, I've seen a lot of different things, like, you know, on top of Olympus tops, where they're talking about, oh, it's oculomotor. Just think about what you're doing. I mean, if you just think about it, I mean, it's exactly what it is. And then you can kind of do some application of the testing on it. So why do we do it? Well, we said that the brain is, I'm sorry, the brain is stuck in this hole here. And it's the skull, right? So when you have the brain here, there's no place for it to go. So when the increased intracranial pressure, as in a concussion, contusion, epidural bleeds, subdural bleeds, subarrachnoid, all cause intracranial pressure. And as that intracranial pressure, and this is why we look at cranial nerves, is we try to assess, are these becoming problems? However, in a stroke, it affects that cranial nerve. And like we said before, with a light switch, damage is done, all done. So now that cranial nerve damage is the damage that is done to that part of the brain. And then that's why we have stroke applications and rehab applications. All right, any questions? Helpful? I'm talking to myself. How about that? I'll just say that. People are like, I fell asleep. I don't know. I'm zoned out. I'll watch this video later. Right. Okay. You know who you are. All right, so let's get into it. Let's move to the next thing. All right, so let's see for time how we're doing. So we're doing good for time. All right, so moving on. All right, so put your neuro hat on, right? So this is neuro. All right, wait. Each bleed, does it really have a specific symptoms? No. It's always the pressure, right? But all bleeds will generally affect the pupillary response first. Yeah. So put your neuro hat on, right? So the big principle is that and the reason we put our neuro hat on is because it's a neuro question. All right. So on neuro questions, you have to just recognize that it is a neuro question, right? And that's the problem with NCLEX and comprehensive tests, because sometimes you don't realize, hey, we're in neuro land here. And when you're in neuro land, put your neuro hat on, forget what you used to learn, and just memorize what you need to know about neuro. It's gonna, and then if you're confused and you don't know what to do, say, all right, well, I know normal shock would be increased heart rate, decreased blood pressure, but in neuro, So if you're not sure, say you know normals, say, okay, well, it'll be the opposite then. It'll be decrease heart rate, number vagal, and then increase blood pressure, which is normal. How do you differentiate the sizes of the pupils? Yep, we're going to talk about it right now. Okay, the size of the pupils, and let's get into this. All right, so I'm working from this sheet here. Make sure I got it. And we're going to start with, we already talked about the spinal thalamic test, right? So the spinal thalamic test is what we were talking about with risk versus flaccid, right? So the principle is this, right? So when you're talking about neurological structures, right, this is this diagram that you see a lot. And they're talking +3 reflexes, right? +2, you know. That would be ipsilateral, right? So there's a difference. So we talked about that with like magnesium, calcium, right? We said that increase in mag would be, you know, less reflexes, right? +1s, 0s. Because we said that increase of mag is slow, like symptoms, right? So think about mag, tocolytics. And we said that calcium, high calcium, is slow, like symptoms. So there'll be hyporeflexia, where low calcium is fast, like symptoms, which will be hyperreflexia. Okay, that's electrolytes and reflexes, right? But when we're talking about neuro and we're talking about damage, we're talking about the test, and that was kind of what we were talking about with the spinal thalamic and then the feathers, right? I know it looks like a leaf, but it's in the brain. And that's what you're looking at. And we also said with an EMG test and all those things, but that's not what we're talking about with this. That's just a neuro assessment. I don't really test on that, but that reflexes with NCLEX tends to be focused on generally this area, magnesium and calcium and stuff like that, or Guillain-Barré, which we talked about, and but not so much you sitting around doing these type of tests for the patients. Most likely is that you're going to take care of patients with magnesium and calcium problems, not that they're going to be, you know, neuro patients, right? And they're going through this process right here. So always remember, this is kind of where you're going to be studying. This is what you're going to be tested on for your NCLEX and stuff like that. We saw that in a question, I think yesterday, or we did it. All right, so that's the first part. Then we have pupillaries. Okay, so we have pupil responses, which is this part right here. So as we're looking at pupils, right, so some basic things, right? Meiosis, mydriasis. D for dilation. No, dilation. Okay, so once you know that, right, so this is dilation, right? So that means that they are going this way. They're getting bigger, right? And meiosis is the opposite. It's pinpointing. Okay, so kind of go like this. All right, so bigger, mydriasis, meiosis. All right, so let's talk about it. So 2 to 4. Now you'll never be tested on them showing you pupils, right? But you will be tested on numbers. Okay. So meiosis. I think I spelled it wrong. Meiosis. All right, so some things to think about. All right, so pinpointed. All right, so pinpointed generally tends to be medications. Because normal mechanisms means they should contract, right? And they should, right? We said that they should go up and they should go down. They should react to light, right? That's called Perla, right? Pupils reactive to light and accommodation. Right? That's what you learn in 1, 2, whatever. All right, so what's some principles we need to know? Well, fixed is always bad. Okay? So fixed is always, always, always bad. Unless it's a glass eye. Okay? So if they have a glass eye, I mean, you hope for that, right? I mean, but that requires assessment, right? I mean, patient has a glass eye, it's fixed pupils. I mean, that's what you'd expect. Okay? So some things that with fixed, right? So fixed is acute, that's now, and then sluggish, slow, bleeds generally. Okay, doesn't mean it can be something else, but generally slow bleeds or medications like opiates, different things like that. All right, so pinpointed. All right, so what's most likely for you guys, right, is opiates are pinpointed. Now, epinephrine drops for the eyes. Think about this. Epinephrine. Is it alpha or beta? It's alpha. Okay. A flipped upside down is V, which is vasoconstriction. Vasoconstriction causes pinpointed. So it's a short leap, right, for epinephrine drips. I have chemical nerve gas, which you'll never get tested on. Intracerebral bleeds, and then are narcotics. Okay. And they get pinpointed on a bleed because it goes back to pressure. Intracerebral bleed. So what is that? I haven't really talked about that. So think of subarrachnoid hemorrhage, intracerebral, inside. Okay. And you go back to the eyes, and you talk about pressure. Then you think about my finger, and pinpointed. So it gets stuck on pinpointed constriction. Fixed pupils, we talked about, sluggish, right? Underlying cause, and then dilated. So then dilated, so the numbers 2 to 4, right? So 2. Now you will generally get 2. You're never going to get 4, right? So that tends to be more pinpointed, okay? And then that's that fancy light that you get, you know. I mean, it has all the different things on it. So dilated, so 4 to 8. So they'll give you 8 if they ever give you that. All right, so that's dilated. So the first question is it fixed or is it not? If it's fixed, that's acute. Right? If it's just dilated, so then we look at the underlying cause. Right? Could be a concussion. Oxytocin. Hello, Brenda. How you doing? All right, did you teach this? Just wondering. Oxytocin will cause dilation of pupils. And then meth. Okay. Whatever. And then atropine, right? And cocaine. So what are you responsible for this? Okay, well, I mean, pupillary responses in a nutshell is look for the underlying cause, right? Is it fixed, and where are we, right? And knowing these terms, meiosis versus mydriasis. And so if they said patient has mydriasis, you know that means they're dilating. Okay? So underlying cause, and then if it's pinpointed, meiosis, you know, underlying cause again. Fixed, that's always a big question. Sluggish is always a problem. You don't leave a patient with sluggish pupils, right? You always are assessing why. Okay. Now, what about brisk? Okay. Brisk is usually in addition to other things. Okay. Not necessarily underlying, but it's never generally. There's so many factors. So think of brisk being like nausea. Okay. When we talk about nausea, nausea is kind of in a lot of different things. All meds cause nausea, that type of sense. So when you see brisk or something like that, you're looking for reflexes, right? So hyperreflexia, this and the other thing. So a patient with hypocalcemia would have brisk pupillary response. All right. So pupils. So if you see pupils in a question, you put your neuro hat on, and this is all it's about. It's about either being fixed or sluggish, and it's basically saying that bleed or brain injury or medications. And medications are just expected, like opiates, or you gave drops. Now, drops tend not to be pupillary testing on NCLEX because drops are based on glaucoma, right? And whether you give anticholinergics and atropine and all those type of things with the glaucoma. And we've seen questions like that. All right, how are we doing for time? I think we're over. Nope. All right, so we'll keep on going. All right, any questions right now? Oopsie daisy. All right. I don't know what that is, Kara. Is that a hand up? All right, so what's next? All right, let's talk about some specifics, right? So let's talk about Sabine's questions. Is fixed? No, it's not doll's eyes. We'll talk about doll's eyes. If you're doing doll's eyes on a patient, you're talking about they've herniated and they're dead. And you're trying to see whether or not they are really dead or not. And that's kind of what that's about. All right, so let's talk about, and pupillaries are generally, unless it's fixed, not quite dead yet. All right, so continually assess this patient, figure out what's going on. You know, if pupils are in a question, it's a question about underlying cause. This is a brain injury or a medication question. All right, so let's talk about GCS. All right, so GCS is next, and GCS is Glasgow Coma Scale. I'm talking about this part right here. All right, so now let's talk about what do you need to know. All right, so NCLEX will never have you assess a Glasgow Coma Scale. All right, because it's subjective, objective, right? So I mean, it's not the rule, but you need to know about it, right? So that's the big key about it. It's just basically an assessment, a tool that we use to assess patients and their neuro level of consciousness. A lot of times in squads, you know, I mean, it's big on squads because a lot of times you want to know, you know, is that patient, what's their GCS? Because that GCS will tell you, what's that patient look like coming in to the hospital? And I'd want to know that. I don't know what I'm drawing up here. Whatever. And so when that patient comes in, you know, GCS is important. Okay, so let's talk about it. So 15 is you or I right now. I'm definitely a 15. I'm alert today. A lot of you might be, you know, 13s, you know, sleepy or whatever. So that's what you're kind of talking about. 15 is alert. Okay. 8, intubate. So just generally think about it that way. So if a patient has 15 and is suddenly 8, you're thinking intubate. All right, because when you're looking at those things, you know, there's 3 different areas that you're going to look for. EVM, right? Eyes, verbal response, motor response. So let's kind of walk through all of them, and we'll kind of go through it. Now, what are you responsible for? You are not responsible to memorize this, all right? Because you just need to know what it means, right? So GCS 15, you were right. 8 is intubate, and less than 4 letters in coma is coma. Okay. All right. So eyes. There's numbers that you give them, right? So you have 4 through 1. Remember, you don't need to know these numbers, so I'm not going to ask you to, you know, calculate it. Nor will the NCLEX. Study what you need to study. So eye opening. You know, are they spontaneous? Do to voice, to pain, right? So a lot of times what we do is that we might do a sternal rub, right? So pain, or, you know, I know ACLS now teaches you to do finger pressure, right? So pain response. Now you think about that. So if a person, if I said, hey, you know, Kara, are you awake? You know, and then, you know, you should be a 4. You should be alert and say, hey, what's going on, right? So, however, if you give a lot of medications like opiates, and the person is sleepy, and they might be sleeping, but you say, hey, are you okay? And they wake up, okay, so their baseline is a 4, but now they are waking up to voice, right? But maybe they don't wake up to me saying, hey, what's going on? So then I have to go to the next thing, which is pain. Okay? Sternal rub, finger pressure on the finger, and stuff like that. And if these are natural mechanism to pain is to withdraw. Okay, so if you give somebody pain, their natural mechanism is to withdraw from it. So if you have a sternal rub and you sternal rub somebody, they're going to move. Okay, and that's a response to pain. All right, a 1 on the eyes is nothing. So you've talked to them by voice, you tried to wake them up, tried to put pain, there's nothing. You get no response. That patient's more acute, so they have a lower number. So next is verbal response. Okay, can they talk to me? Normal conversation, right? Then you have disoriented conversation. Words are not coherent. No words or only sounds, they're just mumbling, or there is no response. So lower the number, the lower the thing. So if you think about it, they have no verbal response, no movement. You only have a 2 right now. That's bad, right? Where 15 is normal, but they have a 2. So we go down to the last thing, motor response. Okay, so normalized, right? Now, so if you were to, you know, do a sternal rub, right? And they say, what are you doing? Like, so if I sat down and suddenly started doing a sternal rub, you know, I mean, I don't need to go over where the sternum is, but if I started doing a sternal rub, you're like, what are you doing? Get away from me, right? So, I mean, that's a normal response, right? But if it's localized to pain, what does that mean? Is the hand moves and localizes to that area, right? So it kind of pushes you away, right? Or a person withdraws, right? Withdraws is, so this is where it gets a little bit subjective, objective, right? And this is why they'll never have you do this assessment. And that's why there's a lot of validity issues with it. It's a good thing to know. NCLEX will test on, do you know the numbers? However, to interpret it, it gets convoluted a little bit. All right. So then we have the corticate and then the cerebrate in the motor response. And that's our next thing as far as posturing we're going to talk about next. But you think about it, the corticate or cerebrate are natural mechanisms of movement. So if somebody had a 1, which is none, 1, none, and 1, none on all these areas, they have a Glasgow Coma Scale of 3. That's less than, they are a coma. This is kind of where we talk about when patients are in a coma. Okay? And so when we're talking about, there's only basic life responses generally. And what does that mean? Patient's breathing, right? The normal mechanisms are breathing. So let's talk quickly about it with why the corticate and the cerebrate. So the next thing is the corticate versus the cerebrate. Well, there's some terms that we need to know. So that's first, okay? So abduction, right? Abduction, and I say kind of move your arms out. Hey, look at my abs, you know, abduction, right? And then adduction, right? Adduction goes in, okay? So those are some terms. That's basic nursing 1 stuff. You're responsible to know terms, okay? And that's important because NCLEX will, it's a very high, what's the word? vocabulary test. So a lot of times you see these words showing up and you're like, what's that? And that's why it's hard. It's hard for English second language a lot of times because you have to relearn these other medical terms on top of it. So abduction and adduction. Right? Hey, look at my abs, is abduction. And epiphoria, yeah, perfect example, right? Teary eyes. All right. So decorticate versus decerebrate, okay? So the way I view this is that now decerebrate, right? Kind of think of it like this: hey, what's going on? Decerebrate, right? Celebration, right? Out, decerebrate, okay? So this generally happens first. And this makes sense because the body would naturally not leave itself open to injury. So think about this. Decorticate and decerebrates are basic life protection neuro structure. So think about when you're breathing at night. You are breathing normally because your basic neurostructure is in place that you breathe normally. Now, if you have sleep apnea, like a big belly and stuff like that, you can get apneic, and then your body wakes up, says, hey, wake up, and then they wake up and they start to breathe. And we talked about that in pulmonary. But with decorticate and decerebrate, cerebrate, celebration, arms go out and everything goes out. With decorticate is basically protection. And I said that backwards, didn't I? Yeah, I think I did, yeah. Yeah. So, not for a second. Oof. First. Second. So if you think about this, why is this first? Because you're most likely to protect yourself on the core level, right? So like I said before, if you're doing a sternal rub on somebody, you're most likely going to push that arm away, say get out of here, correct? And that means you're alert, you're aware, you have a motor response to pain, and you know what's going on. And think about this, this is going to come back when we talk about spinal. You know, a spinal injury patient with autonomic dysreflexia, you know, could be sitting on a tack and they can't feel it, but their neurological structure can feel it. So it sends its body into this crazy kind of response. And that's an important thing to recognize because on our base core, we always try to protect the corticate, protect the core. So just think about the person is protecting the core. Now I show you going like this right now, but it's not like that. It's kind of like this, okay? So it's not like, oh, like decorticate. You know, it's very subtle, and it's rhythmic, and it's over and over. And as a neuro, just think about respirations. You're going to breathe when you're sleeping, a certain amount of respirations because your heart rate's going to be at a certain level. But in neuro, when a person has come down to this part of the corticate in coma at this level, they are what's called posturing. And posturing is always bad because posturing means we are going to be looking at doll's eyes and caloric testing, all right? Not like calories, like a water caloric. So the big thing about this is decorticate and decerebrate. Decorticate is acute. Both of these are acute. This generally happens first. So if you see decorticate in a question, you're in a neuro question, you're in a dead patient's question. You have a patient that is basically has some sort of brainstem injury or is on their way to be having brainstem death or herniation. So decorticate, then decerebrate is celebration, and that means a decerebrate hands will be going out, okay, like that. So where decorticate is more towards the front, and decerebrate is out. All right, and that's the same thing with the legs and everything like that. And decerebrate, the body will generally not leave itself open to injury like that, right? That it's posturing at this way that it just leaves its body exposed. that means that you've lost this protection mechanism, and now you're over to here. And that's the difference between decorticate and decerebrate. Now, the big thing that you have to figure out is doing NCLEX questions and doing more questions, because you have to see how it's phrased. Because they'll talk about pronation, abduction, adduction, and when you're doing question after question after question, it's kind of like the chest tube questions. And those chest tube questions are generally, you know, I mean, 1 minute you're putting in water, 1 minute you're not, and this, that, and the other thing. And so you kind of get confused on what it's really asking. And in neuro questions and decerebrate and decorticate, they're talking about whether or not you know what abduction, adduction is. So you have to kind of draw it out when you're doing it, because they're seeing whether or not you have the understanding of what it is and what it looks like and recognizing. That's a good thing about neuro, is because it is, I mean, you see decorticate, you decorticate. You know, it's what it is. No, it's, you're not going to walk in with a hamburger, you know, for a person in decorticate or decerebrate. You're going to actually, you know, this patient is on their way to becoming brain dead. Well, it's an expected finding. Your patient has a brainstem injury, is decorticate. You know, you don't, you know, order a full tray for that patient. All right, I think that's a good place to stop. Any questions right now?